And thank you for being here. I'm going to get my water. I apologize for my voice. This is probably going to be tougher on your ears than it is on my throat. It's a little case of a little bit too much talking yesterday and not enough recovery after a cold. Again, thank you very much for the invitation to come and speak in front of you today. Just housekeeping issues. I do have a lot of funding, mostly centered around research. I am fortunate enough to be about a 40% lab-based clinician. And as per Dr. Goldenberg's introduction, it's a nice mix as a clinician scientist. And again, thank you very much for the invite. We're now going to swing this into our clinical practice and see if, in fact, hyperbaric therapy makes any sense whatsoever to the patients and whether or not any potential outcomes justify a disruption in their day-to-day life for a period of 4, 6, or 8 weeks. And meaningfully, will this change what happens with the natural history of ED after radical prostatectomy? We all know that the operative morbidity of RP has gotten better over the past 5 to 10 years. Anatomic understanding, refinement of techniques has resulted in better rates of continence and decreased rates of ED. However, there still is a large rate of post-RP sexual dysfunction, and this varies from erectile dysfunction up through and including climacteria, fibrosis, Peyronie's disease. We're really going to look at erectile dysfunction per se, and specifically the non-reversible anatomic changes that occur in the corpora, that'd be cavernous fibrosis, and whether or not we can do anything here. The etiology after radical prostatectomy and the tumbling neuropathobiology that happens afterwards is based obviously on cavernous nerve injury at the time of surgery. Even with the bilateral nerve-sparing approach, we are getting stretch injury, tiny lacerations, etc., which is really resulting in about an 18 to 24-month state of neuropraxia. During that time, what ends up happening, and this has been shown by Peyronie's group, by Mulhall's group, who's working together actually with us on this project, is that you have subsequent changes in the smooth muscle in the penis. And why is this important? It's important because even with cavernous nerve recovery, that nitric oxide that's then released into the system bounces off like a ball off a wall from this smooth muscle, which is now fibrotic and not able to relax and allow for initiation of erection. And the problem here is this is the type of anatomic change and clinical change that's very difficult to treat with first-line therapy such as oral agents. And in fact, one of the sequelae here is venous leak. And if that happens, second-line therapies like injection therapy are prone to failure as well, because we're still able to get the blood into the chambers, but we're not able to trap. What does this mean to the patient? It means that their options for maintaining or returning sexual function are really limited to a penile implant or nothing. And again, contemporary practice right now does have some holes in it, and this is what I hope we'll address today through the course of the talk. The next thing to identify is, does this really matter to the patient? Does it matter to the partner? Are we talking about something where men are going to be willing to do something extra for potential effective return of spontaneous erections? Looking at quality of life metrics, we know that ED is the most common concern after cancer control and after incontinence. So yes, the indication is there. Why is this? It's because of the acute nature of what we're doing. We're good at controlling the cancer. We're good at continence. We still have the final frontier, as Bud Burnett put into the AUA News editorial in the last issue, of a gap in knowledge and a gap of clinical strategies to use for men with ED. And this results in significant morbidity. And we're not just talking impotence. We're talking actually global changes in day-to-day life, which spawn from ED, especially ED that is very difficult to treat. And this happens in the home, it happens in the workplace, using a variety of criteria from the UCLA RAND scale up to including what productivity is like at work. We see that there is actually a significant compromise in these patients if you do have especially treatment refractory erectile dysfunction. I was fortunate enough just to be working with the NIH looking at a critical review of the trials that have been put into the literature in the last 10 years on post-radical prostatectomy ED. And the bottom line message here is 2 in 3 men who are going to surgery are going to have meaningfully compromised erectile function. Run Wang put it very nicely. when he looks at post-radical prostatectomy ED, it's actually quite simple. You have multiple hits, starting at a neurovascular level, going through an anatomic level psychologically, which compromise erectile function. But to the to the patient, when they look down, all they see is a small atrophic penis that's not working, and this equals an unhappy penis. Recovery of erectile function after radical prostatectomy, the parameters involved have been pretty well defined. And if you were able to be at the talk last night, we did go through this in quite some detail, especially looking at age, neurotrophic factors, the neurobiological response to cavernous nerve injury. It's beyond the scope of what we can do today because we're trying to keep it practical and focused to making a decision whether or not hyperbaric may have a role in these patients. Tom Liu has a great way of looking what we're doing with ED after radical prostatectomy. All we're doing at this time is reacting to the insult. We don't actually have any way of modifying the primary insult, getting there early and changing the subsequent pathophysiologic changes. What we're doing is we're actually reacting to the secondary effects. So if we have apoptosis, we have hypoxia, we have these changes that are occurring. Patients are on PD5 therapy, patients are on injection therapy or combination therapy. That's really where we're at with contemporary practice. And it obviously has some limitations because we're not really adapting to what is going on from the surgical injuries that we're giving the patient. So where are we at in 2008? And do we even need to have me standing up here talking about hyperbaric? We believe that there are changes that occur with our current treatments, or the fancy term post-radical prostatectomy penile rehabilitation. These are based on two broad categories. One is trying to help the nerves in that they're protected from further injury or you're helping recovery. Secondly, and more importantly in our case, we're trying to modify the fact that after cavernous nerve injury, you lack oxygenation through recurrent erections, nighttime, morning, sexually stimulated in the corpora. And in biopsy studies taken before surgery, 2 months after surgery, and 12 months after surgery, we know that there is permanent cavernous fibrosis that's occurring, and that's our target with hyperbaric therapy. The primary indication would be trying to modify what is going on at a molecular level because of a relative hypoxia and allow for these men who would then be requiring injection or penile implant as their erectile dysfunction therapy and shift them to spontaneous or PD5 responders. Because if you do have functioning smooth muscle, you are more apt to respond to first and second line therapies. There is a lot of basic science and small-scale human studies out there that is trying to establish a baseline of literature to show that there are endothelial effects of what we're doing post-radical prostatectomy penile rehab, enhanced nerve regeneration, and again, we're looking at preserving cavernous smooth muscle function. Historical note, where did this all begin? It began with Montorzi's study. Small numbers, big effect, initiated penile rehabilitation. And again, ICI therapy ended up becoming the mainstay based on this paper of looking at modifying the response to radical prostatectomy and subsequent ED. Since then, we're trying to come a long way, but we're actually doing it in small incremental steps. One of the exciting things that will be coming out later this year is the first larger study looking at whether a nightly dosing of a PDE5 inhibitor actually has a meaningful end treatment effect on recovery of sexual function. And here we're talking about spontaneous or PD5-assisted erections. If we're talking about this being exciting, it means that there's a gap of knowledge there right now. And there is. We are using PDE5 inhibitors either on a nightly basis or on a program basis as part of penile rehab. But again, there is a baseline level of evidence there, mostly animal, but is very incomplete. And in fact, if we're looking at sole treatment with PDE5 inhibitors for most men, that's likely not enough. So with the limited evidence, what are we doing now? The caveat here, this is best evidence and opinion leader-based practice. We can't really have standard practice guidelines because the data doesn't exist. It appears that having early assessment of the patient either before the radical prostatectomy and outlining the rehab options or early after prostatectomy, we're talking about when the catheter is coming out within a couple of weeks, tends to allow the patient and the partner to make a better informed decision and actually get going with these therapies earlier. And why is this important? It's important because if we look at the basic science of what is going on, the nerve changes and the cavernous smooth muscle changes are starting at about the 2 to 4 week mark. So if we're going to try to rationally modulate this, we should be doing it at an as early basis as possible. The evidence for starting things prophylactically before surgery or right at the time of surgery is actually scant, inconsistent, and you really can't hang your hat on it. So again, there isn't a set formula as to what we should be doing. Most surgeons at this point in time will try first-line PDE5 as their penile rehab strategy. I think this is entirely appropriate. As long as within the first 1 to 2 months after initiating PDE5s, there's a reevaluation to see whether or not an erection sufficient for penetration is attained. Because if it's not, we're not optimizing this return of cavernous smooth muscle function, and you at least need to offer, discuss with the patient the ICI therapy regimen, usually in combination with either a chronic dosing or a strategy of programmed PDE5. Do we know when treatment initiation is best? No. And that's why there's a question mark there. We don't know. Most would now be starting a penile rehab strategy within a couple weeks of surgery. Which brings us full circle to the question that we started off with. If we're going to ask men to come in and spend their time and try to help with recovery of erections, is there a role or evidence for this? Judd Mulhall just published this in March. Animal study looking at hyperbaric therapy and recovery of erectile function. So this is hemodynamics and pressure changes in the penis. And what we're seeing, the group to the left in the circle is a crush injury in a rat with no hyperbaric treatment. The right-hand side is a meaningful, clinical, and statistically significant, of course, in a rat response with hyperbaric therapy. So again, we're laying the foundation of the groundwork for some animal evidence to show that, yes, this makes sense after nerve injury. And with regards to cavernous smooth muscle, we're going to see in the next slide that there is also an endothelial protective effect. So here we're looking at nerves. And the literature is a little bit divided on peripheral nerve hyperbaric effects. But in Mulhall's study, what they were able to show for nerve growth factor and for endothelial NOS, that this group right here, you're showing increased levels after treatment, after a period of observation, and better recovery of erectile function. So again, it's starting to make sense. We're starting to build a baseline of literature. CD31 is a marker for endothelial function. And what you wanted to see here was basically not a change between groups, normals that are non-crushed and the group that had the hyperbaric. And that's what happened. So we're targeting two different molecular aspects. So the question is, we're talking animal evidence here. Is there enough to really proceed with a study of hyperbaric in human? Well, we have a mechanism. We know that hyperbaric helps with oxygenation. We know that the cavernous smooth muscle is basically dying and fibrosing because you're not getting levels that are adequate. So it seems, at least from a pathophysiologic standpoint, that yes, there may be an indication. Do we have a patient population that could benefit from this? Yes. In the short and medium term, it is highly unlikely that we're going to drastically change how we're managing our prostate cancer. So I think that cohort of patient is going to be there. Does ED, and now we're going to talk a little bit about incontinence in the next slide, confer significant morbidity and decreased quality of life? Yes. So now we have something that the patient can actually look at, identify, and say, hey, you know, this may be something that I'd like to consider. And again, the last question to answer is the contemporary standard of care as best as we can do. The answer to that is we're not sure, but I think we can do better. So the proposal here is actually an additive study to current management. And by that I mean that you would have one group that's on PDE5, program therapy. In addition to that, early post-surgery, you would piggyback hyperbaric oxygen in a program of 30 to 40 sessions, probably on a 5-day-a-week basis. So it's a significant commitment by the patient to time spent. But again, it's in concert with what is being done already. I think the second important thing is to be able to switch over or add intracavernous injection therapy. And between Drs. Mulhall and Goldenberg, we have now been able to tweak the protocol that's in development to have a crossover, a switch over to possible ICI therapy. Whether it's at 4, 5, or 6 months, there's really no evidence to show which one to go with, and that's still in development. We talked about a sham group. In this case, we actually have something to compare against, PDE5. So we can run this as a 2-arm trial, trying to keep the numbers down, trying to keep this manageable. The The design will really be an initial feasibility study first, because again, we need to see whether or not we have buy-in by the patients. Are they willing to commit to a little bit of a prolonged course? Finally, no one at this point can say whether or not there will be a potential continence benefit. But again, we're talking about oxygenation and muscle. And there is a chance that not only will we be targeting erectile dysfunction, but we may have meaningful effect on either an earlier return to continence, or for some men who may have more significant incontinence, there may be an improvement. But here the evidence is a lot weaker, and that's why I'm only qualifying it as a statement. So again, thank you very much for your attention.